Dr. Welch is a professor of medicine at the Dartmouth Institute for Health Policy and Clinical Practice. But more importantly, he is known for his work and articles in the lay press about overdiagnosis and concerns about cancer screening, and really asks the question, are we making people sick in the pursuit of better health? And part of the reason we love his work is because he's been really thoughtful and asks questions that we often think about in clinical practice, but maybe don't know how to say. So I really am grateful for coming. Thanks, Gil, and welcome to Bay State.
All right. Can you turn the lights down a little bit on the screen?
I'll work on it.
Good morning. Can you hear me? You didn't ask about any disclosures.
I didn't. I'm sorry.
I thought I was supposed to do disclosures. I'm a Philadelphia Eagles fan. Don't you love it when Nick Holt caught that? Come on, you guys. I've been living in New England for 25 years. I'm not reeling you in on that. Here I am at Foxborough. Some of you may remember my friend Drew Bledsoe. No, I guess not. Yeah. All right, let me just be clear about one thing. I let the air out of the footballs. Tommy didn't do it. Other disclosure, I'm 62 years old. And 62 years ago, I was born an affluent American. It is what it is. I can't change it. Here's a picture of me. This is real. I got this from my mom, old technology called Kodachrome. Some of you may remember it. And the clinicians in the room are beginning to recognize there's clearly something wrong with that child. I mean, it's clearly overweight, right? I mean, there's no question about that. Probably has toddler hypertension, hyperlipidemia, glucose intolerance. And then look at that face. The pediatricians have a term for this. This is an FLK. It's a funny looking kid. I probably have a bunch of single nucleotide polymorphisms, a couple of genetic variants, and maybe even a frame shift mutation. But the real question is, what is going on in there? Look at that thing. Could that be an early abdominal aortic aneurysm? Oh my God, I'm so glad I was born 62 years ago. I want to talk to you today about 7 assumptions that drive too much medical care. And I have a disclaimer, and that is, I really believe medical care can do a lot of good in selected settings. You may sort of tend to forget that as this talk goes on, but I definitely believe we can do a lot of good for people, particularly when they're acutely ill or injured. But at the same time, our traditional concern about getting too little medicine, there's a recognition that it needs to be balanced by a concern about getting too much. In a recent survey of primary care practitioners in this country, nearly half thought their patients got too much medical care. So the challenge for us is, can we communicate the nuances of medical care? In other words, some is good, but more is not necessarily better. Also, disclosure, I have a book on the topic. It's called Less Medicine, More Health, 7 Assumptions that Drive Too Much Medical Care. And in the language of our president, it's a great book. You should read it. It's an awesome book. I have other books on the topic, Overdiagnosed, Making People Sick in the Pursuit of Health, with my colleagues Lisa Schwartz and Steve Voloshin. And my first book, Should I Be Tested for Cancer? Maybe Not, and Here's Why. And these books have lots of numbers, charts, and graphs. So for those who are data-oriented and want a read where you can really see some information, I suggest those 2 books. My publisher said to me, there's a group of people, about half the population, the minute they see a table or a figure, they say the book's not for them. So this has nothing. In fact, the title could be Less Data, More Narrative. Did I say it was a great book? I did, okay. And if all this is just beginning to feel like another advertisement, the medical advertisement, I want to be clear, I have no financial interest in any of the books. I made that decision with my very first book, Should I Be Tested for Cancer? Not because there's so much money involved, but because I didn't want people to say, oh, the only reason he's saying these things is to sell books. All the royalties from the books, such that they are, go to Upper Valley charity. Charities in the Upper Valley of Upper Connecticut Valley, which is Vermont and New Hampshire. What am I saying? Assumption 1. All risks can be lowered. And of course, medical care can reduce some risks, but the effort's most likely to be successful when the underlying risk is high. Imagine someone with a really high chance of something bad happening in the next 5 years, like 50%. By bad, I mean, heart attack, stroke, renal failure. Sometimes medical care can dramatically reduce that risk, even cut it in half. That's the case with treating people with really, really high blood pressures. But most of us are not at really high risk for something bad to happen. Our risk of something really bad happening in the next 5 years is at most on the order of 2 to 3%. And it's hard to lower an already low risk. And all of our interventions, all of them, pose some harm. Now, the importance of so-called baseline risk, where you start, first became evident in the treatment of high blood pressure. And I want to start with a rather complex slide to share 4 randomized trials with you of treating diastolic hypertension. And on the y-axis, I've got the annual rate of death or end organ damage being heart attacks, strokes, renal failure, etc. And I will start by showing you the untreated groups. And here's very mild hypertension, here's mild, here's moderate, and here is severe. And maybe this is a long run for a short slide, but who's at really high risk for having some bad outcome? Someone whose blood pressure is really high to begin with. This is the spectrum of baseline risk, from relatively low to relatively high. I said these are randomized trials, so let's get the treated groups up here. They're in the yellow. And the benefit of treatment is, of course, moving from the red bars to the yellow bars. That difference there, which is the so-called absolute risk reduction. Noisy slide, let's just take that away, and this is the picture of treatment benefit. Treatment benefit rises steeply with the underlying baseline risk. That's an important relationship in medicine. So we've got this spectrum of baseline risk from borderline hypertension to severe hypertension, and I said all of our interventions pose some harm. So I've got to have a harm curve up here. And there's a little bit of uncertainty about where exactly that should be. What's the slope? Make it wiggle. And some of you might say, well, Gil, you got the slope wrong altogether. It should be a negative slope, because who's most likely to be made hypotensive, fall, break their hip, end up in the unit? Well, someone whose blood pressure isn't so high to begin with. Be that as it may, a little bit of uncertainty about what that harm curve looks like. My main point here is that treatment harm is less related to baseline risk. It's more a fixed effect of whatever treatment it is we are considering. It's less modified by exactly what the baseline risk is, while treatment benefit is highly related to it. If that's true, clearly there's an area of net benefit, but at least conceptually we have to worry about an area of net harm, largely because there's so little benefit to be had. Now, the importance of baseline risk is obscured by our tendency to describe the benefit of intervention in relative terms. And this involves some advanced mathematical constructs that I don't know if the residents will be familiar with them. The subtraction, have you guys had that yet? And division. All right? So let's see how you guys do. Let's say you're buying a car that lists for $50,000, but you get it for $25,000. How much did you save? If you do the subtraction, how much did you save? Oh, come on, shout it out here. What is it? Get this group going. Okay, 25. And if you do the division, how much did you save? How do we normally talk about it? 50% off or half off. All right, so that's the absolute change. The subtraction is the absolute change. The division is the relative change. Now, Let's say you're buying a popsicle list for $2, but you get it for $1. How much did you say? Do the subtraction. $1. Do the division. And then you see the problem. Right? Everybody can see the problem. Everybody can see the problem that 50% off from what? A relative change tells you nothing about what you're getting 50% off from. Now, 50% off sales, I don't know if you know this, but we don't offer that many of those in medicine. Right? Most of our interventions, we're lucky if we can, have a relative reduction on the order of 10 to 20% off. And the point here is, it really matters whether I'm being offered 10 to 20% off from here, or whether I'm being offered 10 to 20% off from here. That's really important. Those are the kind of questions I want doctors to ask and I want patients to ask. Oh, by the way, just to make this graph a little bit more complex, let's include the number of affected individuals up here on the top. Turns out there are relatively few people with severe hypertension, but it's just, we've got loads of people with borderline hypertension. And this isn't just about high blood pressure. This could be applied to borderline diabetes to severe diabetes. You have relatively few severe diabetes, you got loads of borderline diabetics. And when I was a resident at the University of Utah, our goal for type 2 diabetes was a hemoglobin A1C of 7 to 8%. And then someone said, no. What you should do is you should try to get patients with diabetes to have normal blood sugars, a hemoglobin A1C less than 6%. Wow, so what's the effect? Just think for a second, what's the effect of a decision like that? Well, first, you've got a whole lot more patients to treat. Right? A patient with a hemoglobin A1C of 6.5% wasn't a patient before that needed treatment. Now they are. By the way, this may lead doctors to have so many more patients that they miss the group that they most importantly should be focused. They get distracted. But who are those new patients? They're the people who arguably stand the least to benefit and are arguably at the highest risk for net harm. Any evidence for that? Well, some of you may remember in 2008, NIH said, well, for safety, NHLBI changes intensive blood sugar strategy. Changed it. Oh, they didn't change it. They stopped it. Why did they stop it? Well, because there was a 22% increase in death from 60 to 73 per thousand. It was hurting people. We can't just lower people, make them normal. We bounce it around. It's a variable. We take them too low, actually increase the death rate. And I gather that yesterday, the American College of Physicians has now relaxed their blood sugar guidelines. I think that's important. The assumption is all risks can be lowered. But the disturbing truth is risks can't always be lowered, and trying creates risks of its own. Assumption 2 is it's always better to fix the problem. But that's not necessarily true. Sometimes it's better to manage the problem of heart disease with real food, regular motion, and a few good medicines than it is to try to fix the problem of heart disease by inserting wires, blowing up balloons, and placing stents. A group of procedures that goes under the name PCI, percutaneous coronary interventions. Well, since I'm here at Bay State, I want to make this point very clear. If I'm having a heart attack, I'd like to have the problem fixed. So the cardiologist, if I have a heart attack, take me up to the cath lab. And the reason I say that, well, we've done a lot of meta-analyses on sort of comparing PCI versus the prior standard, which is so-called clot-busting drugs for heart attacks. Lots of randomized trials, and the summary evidence is something like about a 27% fewer deaths associated with immediate PCI. And you might say, boy, you've sort of forgotten what you were talking about a minute ago. That's a relative change. You want to see the absolute effect. And the absolute is 7 versus 9% died. And you might say, well, that's not that big of effect. But wait a second, we're talking about the outcome of death, and we're also talking about my death. And we're talking about it within 30 days. This is really near. Time really matters. That is a real near-term risk. So, yeah, I'll take the PCI, thank you. PCI is also associated with 65% fewer second heart attacks. That's 3 versus 7%. And PCI also led to fewer strokes and fewer bleeds than giving clot-busting drugs. So I think it's safe to say, in general, PCI is a better treatment for heart attacks than medicine to dissolve clots. That's not that radical. But most patients undergoing PCI in the United States are not having a heart attack. Over 2/3 are elective procedures. And the trial that informed us something about that is the so-called COURAGE trial, which randomized 2,300 patients with stable angina, and the intervention was immediate PCI or optimal medical therapy. Findings at 5 years, in the PCI group, 19% of patients had died or had a heart attack, while in the best medicine group was 18.5%. If anything, medicine looked better, but that's not statistically significant. Nor was the finding in angina at 5 years. By the way, just this year, basically PCI versus sham procedure, really carefully done trial, found about the same thing. And here's the title of the editorial in The Lancet, Last Nail in the Coffin of PCI and Stable Angina. Well, this should sound familiar. Now we've got a little different spectrum of risk, but we're talking about the spectrum of risk from having a heart attack down to no symptoms. I think PCI for heart attack somewhere up here. PCI for angina is probably right about here. And unbelievably, probably about 1/3 of our PCIs are for somewhere down here. Anybody know who that is? Yeah, George W. Good call. Good call. Working the ranch. Working the ranch in Texas. Here's a nice picture of him. And he's a very active guy. Runs, works the ranch, clears brush. He's a mountain biker. He felt fine. He went for a checkup. He got a balloon and stent. Do you remember that? Now, what I thought was remarkable was that some American doctors said exactly what they thought. Writing for the Washington Post, it's worth noting that at least 2 large randomized trials show that stenting these sorts of lesions does not improve survival. Because Mr. Bush had no symptoms, it's impossible that he felt better after these procedures. Instead, George W. Bush will have to take 2 blood thinners, aspirin and Plavix, for at least a month, probably a year. While he takes these medications, he'll have a higher risk of bleeding and no real benefit. And then, this is the head of cardiology at Cleveland Clinic. This is really American medicine at its worst. It's one of the reasons we spend so much on health care and we don't get a lot for it. In this circumstance, the stent doesn't prolong life, it doesn't prevent heart attacks, and it's hard to make a patient who has no symptoms feel better. It's hard to make a well person feel better. Not hard to make them feel worse. The assumption is it's always better to fix the problem. But the disturbing truth is trying to eliminate a problem can be more dangerous than managing one. Assumption 3 is sooner's always better. And we've all been taught that early detection is the best way to deal with a feared disease like cancer. Try to find it early. But our understanding of cancer is changing, and ironically, it's changing because of the side effects of early detection. In the past, doctors treated a population. Each dot is meant to be an individual. Of course, we didn't use the word population. We treated a community. But our strategy was to wait for problems to develop and then make diagnoses and treatment in the fraction that developed problems. Now, the early diagnosis ideal was really appealing. It was to take that same population and advance in time the point of diagnosis. And it had a hidden assumption, is that what you would find there early was destined to be those that were destined to have problems, that the natural history. And that was the model, and it was very intellectually appealing. But the reality has been quite different, that whenever we look for early signs of disease, we find more patients. And that raises a whole new set of issues. It must be a more complex natural history. Hopefully we've gotten those destined to develop problems, but as many of you know, sometimes we don't because those destined to develop problems do so quickly. But at the very least, we have a new fraction, those not destined to develop problems. And that's the overdiagnosed and needlessly treated fraction. No one's doing it on purpose. It's a side effect of the strategy of looking for early disease. Now, we need to think about the word cancer differently. Not all abnormalities that carry the pathologic diagnosis of cancer will ultimately matter to the patient. And that brings me to the barnyard pen of cancers. And there are three animals in the barnyard: the birds, the rabbits, and the turtles. And the goal of early detection is to fence them in, to catch them early. And some of you see the problem right off. You're not going to fence in a bird, right? The bird is already flown away. And these represent the fastest growing cancers, the most aggressive cancers, the cancers that have already spread by the time they're detectable. Screening doesn't help with the birds. The question with the birds is, can you treat them? Now, the rabbits are hopping around, and you can catch them if you build enough fences. These are the more slowly progressive cancers, where screening arguably has an opportunity to help. And then there are the turtles. And you don't need any fences because they're not going anywhere anyway. These are the lesions that meet the pathologic definition of cancer, but they're not progressing. Or they're progressing so slowly the patient dies of other causes before they ever manifest. Or they regress. Really interesting concept. The unfortunate reality is screening is really good at finding turtles. It's really good at finding turtles. And yet doctors aren't able or good at separating turtles from rabbits, so we treat everybody, thereby leading to the major harm of early diagnosis. Here's an article from Life magazine, a plea against the blind fear of cancer, written by a cancer surgeon at the Cleveland Clinic, George Kreil. Just want to read one paragraph to you. It says, in clinical practice, to say that a person has cancer gives us little information about the possible course of his disease as to say he has an infection. There are dangerous infections that may be fatal, and there are harmless infections that are self-limited or may disappear. The same is true of cancers. Cancer is not a single entity. It is a broad spectrum of diseases related to each other only in name. Pretty powerful thought. How many of you are subscribers to Life magazine? Just sort of curious. Residents are looking like, what's this guy talking about? So, I mean, those of you who've seen Life magazine know you haven't seen it for a while. And some of you may realize, like, God, black and white pictures, that must have been a long time ago. It was 1955 this article was written. And it's actually pretty amazing that Life published an article like this in 1955. Really remarkable. That's the year I was born. Just for those of you who haven't been doing the math, 62. I was born in 1955. Well, this is a rude reminder. I've never had an original idea in my life. It's probably Kreil that is the originator of the birds, rabbit, turtle analogy. He was very worried about this issue. It's an uncomfortable reality for us, but there are a lot of turtles out there, and we know that from autopsy studies. That is, when we do autopsies on people who have died from something other than cancer, but we look hard at organs to see what the reservoir of cancer is. 1 to 3% of adults harbor unsuspected kidney cancers. That may not sound like a lot, but that's a lot more than will ever die from kidney cancer. At least a third of adults harbor small thyroid cancers. About a third of women aged 40 to 49 harbor the smallest form of breast cancer, the form that some pathologists wish the word carcinoma was never attached to, ductal carcinoma in situ. And over half of men, and this is probably old news to you, over half of men over age 60 have pathologic evidence of prostate cancer. So I just hope you look at a headline like this a little bit differently. Molecular breast imaging nearly quadruples detection for breast cancer. We've all been sort of trained to say, wow, that's a great test. Let's get it. Until you understand the problem of turtles. Is that just finding turtles? You're finding 4 times as much breast cancer? Is that good for patients? Or how about this? Smithsonian Game Changers. Could a bra actually detect breast cancer? Doesn't look that comfortable, does it? But you really got to sort of wonder, where are we going here? We're going to start putting wearables on people and have them check every day whether they're developing. Does that way we really promote health? Does that really make for a healthier population? Oh, by the way, I got an idea. Anybody want to go in on this? I think we could sell it, though. Could boxers actually detect? Yeah, that'd be. The assumption is sooner's always better. And while screening efforts may make sense in selected populations, particularly those who are at dramatically elevated risk for developing the disease, its widespread adoption has been a recipe for making people sick. The disturbing truth is early diagnosis can needlessly turn people into patients. Assumption 4 is it never hurts to get more information. And of course, this is the information age, right? You all have information at your fingertips. Some of you are looking at it right now. I mean, this is, it's the world. We all think it's always good to have more information. It's sort of the central tenet of our society. But it's a tenet that confuses data with useful knowledge. And it's really important to kind of keep this distinction in mind between data and useful knowledge, because there's no shortage of data out there. There's no shortage of data I could collect on each and every one of you. The Medicare fee schedule, thousands of bits of metabolic data, things we could just run in the lab, thousands of bits. There are millions of pixels of imaging data we could acquire on every one of you, different angles, rotated in space, different weighting. And there are 3 billion data points in your genome. There's no shortage of data we can collect on the individual. Oh, and it can be sent to your smart watch. That's a great thing, isn't it? All right, so every Grand Rounds has to have a case. This is mine. It's a true story. Names have been changed. Bruce is a colleague who's an intensivist. And whenever I say that, I feel like that's a psychological diagnosis or something. But it's not. Yeah, or maybe it is. I don't. Yeah, but he understands how too much data can be a problem, right? This is probably the clinical venue where physicians are dealing with the most data thrown at them in the intensive care unit. When he turned 50, he decided to be screened for colon cancer. Reasonable decision. And his PCP, that's primary care practitioner for the ID guys, was happy to oblige, but also wanted to do other tests. Said, let's get a chest x-ray. And Bruce goes, are you kidding? No, we're not getting a chest x-ray. He's also a pulmonologist. He said, there's no point. There's no reason to get a chest x-ray. Let me check your cholesterol. No, I'm here to I'd like to have colon cancer screening. At least let me get an EKG. At least let me get an EKG. And Bruce said, oh, well, each EKG, that's a pretty simple test. I should, I exercise regularly, everything, and I'm getting tired of this. He's an avid bike rider. He lives in Anchorage. And this is Anchorage, and you're looking at the Cook Inlet there. That's downtown, the background. He rides to work, does over 100 miles a week of bike riding until the snow flies. And he's a big Nordic skier, although not this year because they didn't get much snow. But, and he didn't want to be a difficult patient. Even physicians don't want to push back too hard. So he said, oh, okay. So he gets his EKG, and I'm not a cardiologist, but I do remember it's not supposed to go off the tracing, right? I do remember that much. That's not good. And so then he's told to get an echo, and that didn't look quite right. And all of a sudden, the suggestion, you need a cardiac MRI. Now, cardiac MRI, that's not a simple test, right? You got to sync the MRI to the heart, and you got to change the space planes, and you got a lot of technical issues. And then you want someone who's looking at it that really knows what they're looking at. So Bruce said, look, if I'm going to get a cardiac MRI, I'm going to go to the Mayo Clinic. Have any of you been to the Mayo Clinic? It's a really shiny place, isn't it? It's very shiny. I've been to the Mayo Clinic. Yeah, it has a beautiful atrium. By the way, I didn't check out your atrium. You guys have an atrium? No? Yeah, you got to have an atrium, right? I mean, you got those awards back there. The only way you get those awards is if you have a nice atrium, right? I mean, I think that's how it seems to work. I mean, there's some correlation between atriums and hospital quality. And I'm mocking the Mayo just a little bit, and I know Bruce, as an Alaskan physician, would want me to stop at this point, and I will. At first, as an Alaskan doc, he really appreciates the consultative services that the Mayo Clinic provides doctors in the Northwest, Pacific Northwest, for free on difficult patients. They've been very helpful to him over the years. He also would say that as a patient, he was extremely well treated, remarkable staff, very nice folks, and very efficient. And they were definitely efficient. He got his cardiac MRI. He had a lot of blood tests. Of course, he had his echo and EKG repeated because it couldn't be moved down from Anchorage. You guys know that story. He had overnight pulse oximetry, and he had exercise physiologic testing and went up to 1,000 METs or something. So, is 1,000 not, am I off a couple of minutes? Okay, yeah. Just kidding. So Bruce sat down with the Mayo cardiologist. Then that's how it works with the Mayo. You have 2 or 3 days of testing, and then you sit down with the provider, and to learn the final diagnosis. And it was non-obstructive hypertrophic cardiomyopathy. Barely fits on the screen. And Bruce was going, okay, what should I do? And I like to think the Mayo cardiologist sat back in his chair and stroked his beard. Thought about it a little bit. And he said, well, why don't you come back and see us in 3 years? Now, that's not really a satisfying answer. Remember this train of stuff, this is wrong, this is wrong, this is wrong. Go to the Mayo because you got this problem. It's really not a very come back and see us in 3? That's like, why did I do all this? It's really not a very satisfying answer. But it's probably the right one. According to the American College of Cardiology in the recent guideline, it is recommended that comorbidities that may contribute to cardiovascular disease, e.g. hypertension, diabetes, hyperlipidemia, obesity, be treated in compliance with relevant existing guidelines. Sometimes these guidelines look like they were written by a lawyer. I think that translates, do whatever you were going to do anyway. Right? The data doesn't change what you do. This isn't useful information. It doesn't change what you do. It's non-contributory. So there was really nothing for Bruce to do except worry. I mean, there was real disutility associated with this information. The guideline goes on and says most affected individuals probably achieve a normal life expectancy without disability or the necessity for major therapeutic interventions. Then the lawyer in the next line. On the other hand, in some patients, hypertrophic cardiomyopathy is associated with disease complications that may be profound with the potential to result in disease progression or, yeah, is there zero risk? Oh, no, there's not zero risk. Oh, my God. So all of a sudden, bike riding, and I'll never forget when he was describing this to me. And I included it in the book because it was like such a powerful moment when he said, I just want to share this story. And I knew how much he liked to exercise. And he said, now I feel differently when I exercise. And those of you who exercise know you always have different sensations as you're running and biking and skiing. And if you have something in the chest, is that heartburn? Is that a muscle spasm? Or is that cardiac pain? Real disutility with this information. Oh, the Mayo cardiologist did have one suggestion, genetic testing. Turns out that non-obstructive hypertrophic cardiomyopathy is associated with 1,400 mutations on 8 genes. Whoa! And if Bruce tested positive, what could he do? Well, he could worry more. because now he could also worry about his 4 children. And if his children could be tested, why? Well, so they could worry too, along with Bruce and his wife. And he said he was like dumbfounded. He said, whoa, we're not going there. That's what my daughter calls TMI. That's too much information. That's not helping people. That's just making them live on eggshells. So the assumption should really be, it's not so much it doesn't hurt to get more information, it doesn't hurt to get more data. And you might say, well, look, Bruce felt fine. And that's true. And you can understand. Let's not just go collecting a bunch of data on us when we feel fine. But certainly you would always want more data when you're sick, right? Well, let's think about that. And the residents, I'm picking on you here because this is a chest x-ray. You guys see this? I mean, I went to, let's say, the University of Utah. One said, no, Dr. Welch, that's the scout film for the CT. But anyway, this is a chest x-ray, and as you can see, this person has some hardware that could be a pacemaker or implantable defibrillator. And it's a relatively easy piece of data to collect to see how well electricity flows from the battery pack to the lead in the heart. And, in between is lung, right? And so there should be air there. And if there's air there, electricity won't move well between those 2 points, and the pulmonary impedance will be high. If there's fluid there, though, electricity will flow well, and pulmonary impedance will be low. So here's a single variable, easy data to collect on patients who have this hardware in them. So let's look at a randomized trial on pulmonary impedance monitoring. The objective is now to reduce hospital readmission rates with real-time impedance monitoring. There are 335 outpatients with heart failure and implantable defibrillators. These are sick patients. Their expectation is about 1/3 of them are coming in the hospital every year. The intervention, everybody's got the hardware, is simply to turn the defibrillator's impedance monitor on. So the intervention is simply turn the software on in half the patients, not in the other half of patients. And according to the article, patients with abnormal impedance were alerted with an audible tone. That's a fancy way of saying, what would most of us call that? Alerted with an audible tone. Alarm, oh my God.
Your lung is now filling with fluid.
Jesus.
Your lung is now filling with fluid.
Thank you, Siri. All right, let's see how good you guys are here at Bay State. What do you think the effect of that was on clinic visits? What happened? Oh my God, it was 3 times more. Primary outcome, readmission rates. Up, yeah, exactly the wrong way. 6% versus 22% after 1 year. Mortality? Well, no difference, no statistically significant difference. But yeah, you're right. Actually, a slight increase in the intervention. I shouldn't say, take that away. I shouldn't say it. It's not a statistically significant finding, but it's going in the wrong direction. How about data on cancer metastases? Here, the objective is to find cancer metastases early and reduce mortality. Patients, 1,200 men and women with colon cancer. This isn't screened. These are people with established colon cancer. Question. Randomized half to receive intensive diagnostic follow-up, specifically looking for metastatic disease in the chest, abdomen, and pelvis every 6 months. Essentially a total body CT with CEA. Can we find metastases early if we scan the entire body regularly? Yeah, sure we can. Yeah. What does that do to surgery? More. Oh yeah, more. What does that do to mortality? No difference. Actually, a slight increase. Shouldn't say that. By the way, this is the same finding, and some of you are familiar with a trial about 20 years ago, 2 trials actually, looking at the value of looking for early breast cancer mortality. Yeah, you can find stuff early. Doesn't change mortality. By the way, we should be clear, for our patients, seeking early signs of metastatic cancer can be really scary for patients. All of a sudden, a patient has a new cough. Some doctors might say, well, let's just see how that goes. Maybe you're getting a little cold. Others might say, whoa, that could be a met. Let's get a chest CT. Or new ankle pain, even though you just started running after finishing your chemotherapy. Some doctors might say, why don't you rest a little bit? Others might say, whoa, that could be a met. Let's get a bone scan. That is a real difference in care. Seeking information about early signs of metastatic cancer doesn't help cancer patients live longer, but it does scare many and leads a few to live longer with the knowledge that they have incurable disease. They are then subjected to additional therapies and their toxicities earlier, at a time they would otherwise be asymptomatic. The assumption is it never hurts to get more information, but the disturbing truth is data overload can scare patients and it can distract your doctor from what's important. They get overwhelmed. All right, assumption 6, newer is always better. Has any of you ever bought a new car in its first model year? Yeah, that's fine. Oh, or how about this? Can I interest any of you in beta testing a new electronic medical record? Sound good? Volunteers? Yeah, right. You know. All right, so this is a historical story. Some of you know this quite well. I want to talk about what was a new procedure in 1990. Autologous bone marrow transplantation for women with metastatic breast cancer. And there was early enthusiasm. This is from the Los Angeles Times. Breast cancer survival rate may double, study finds. 10 years later, there's a sobering reality. To a reasonable degree of probability, this form of treatment for metastatic breast cancer has been proved to be ineffective and should be abandoned. A lot happened in those 10 years. Some of you will remember the story. A lot of insurers got sued, some of the biggest, because they didn't want to cover what was, in fact, an experimental therapy that, in fact, cost a lot of money, between $100,000 and $200,000 in 1990. A lot of hospitals got in the market. I don't know what happened. Did Bay State get into this market? Anybody know? I mean, Dartmouth did. I mean, people who hadn't been doing transplants before were awesome because it was a big market. And while the procedure of transplanting bone marrow is technically very simple, the management issues after transplanting are some of the most complex in medicine. The federal judges, Congress, and the executive branch got involved. Congress passed a bill on bone marrow transplantation, and OPM mandated that federal plans covered the procedure, all before there was any data. And some 35,000 women went through hell at the end of life. This was not a happy story. This is a harmful procedure. It's very painful. They spent a lot of time in the hospital. New procedures. You'd like to know whether they work. I want to talk about a new device quickly. This is a pelvis film, and there's no HIPAA violation. It's my pelvis. I don't often do this, but this is my prostate, just so you... okay, that's a few years ago. Now it's more like that. But I'm not going to talk about prostate cancer. I could. I really want to talk about hip replacement. And the first thing to know is that orthopedic surgeons have a lot of choices in hip replacements. Some have racing stripes, overhead cams, that kind of stuff. Really, there's loads of choices. But the central question I want to consider here is what was the old standby, the so-called Charnley hip, with the advance, what was seen as an advance, to the metal-on-metal hip. And the old standby had a metal head and a metal cap, but there was a plastic liner. And the advantage of getting rid of the liner is all of a sudden you could have a larger ball. And there was some theoretical advantage that this would increase range of motion and lower dislocation rates. And the plastic did have a problem. It would wear over the years. Little bits of plastic would be extruded into the joint space. Of course, as you know, plastic is relatively inert. They just sat there. But the plastic would wear. So what's wrong with this picture? Yeah, good idea didn't work. Yeah, it's more than it didn't work, right? It was like worse. It was like 7 times the failure rate. Unbelievable. And what was happening is now you have metal on metal surfaces, and instead of little bits of plastic going in the joint, you have little bits of metal. And metal is highly reactive. Sorry to do this so early in the morning. This is the operative field of the so-called pseudotumor associated with the failure of the hip. You get all this tissue necrosis, inflammatory reaction. It causes a lot of pain. Let's just step back. Why do people get hip replacements? Because they have pain, right? You're trying to get rid of the pain, but these were worse. And now you got to do a revision, and this is a much harder operation. It was a mess. I'm a proud American.
Make those hips great again.
That's what he said. Yeah, you guys proud Americans? All right, I am a proud American. And you know what really angers me about these data is they come from that tyrannical power that taxes us without representation. Now, that's egregious because we did more metal on metal hips than anybody in the world. We do more hips than anyone in the world. And we have to, some podunk third world country with a national health, what kind of crap is that? We can't produce these data. We can't produce these data in this country. We have too many payers. We have people flipping plans to explant. We can't get a big picture about what's actually going on in our own healthcare system. And I can't think of a better argument for a single payer system than simply have a single data system so we can see how well we're doing and what's really happening out there and what's happening with new devices. Oh, and then we have this minor issue of metal ions. You know, and metal, you know, if it gets in the joint, it has a way of getting in the blood. And then remarkably, the same day, the New England Journal and Lancet had case reports on the association of cobalt poisoning from metal on metal hips. I'll share the New England Journal story with you. It's kind of interesting. It's a woman in her mid-50s who all of a sudden develops a cardiomyopathy and has severe congestive heart failure. And so severe that she goes for orthotic, she goes for cardiac transplantation. And then a remarkable thing happened. A few weeks later, the donor heart started to fail. Now, that's not supposed to be happening. You know, the donor's coming from a young person, presumably in a motor vehicle accident, and that heart, and that really threw the docs off. They said, what? Why is the donor heart developing that cardiomyopathy? And then someone goes to the records, looks back, and says, oh, wow, she has a metal hip. Wonder if you should check a metal level. And her serum cobalt was 300 times normal. Don't miss the point here. This is one device causing two hearts to fail in the same patient. It's remarkable. Oh, and a new drug. Anybody remember that? I like, this is on the internet. I won't say a lot about this, but the Vioxx, arthritis pain alleviated even if it kills you. Anybody remember this song? Remember that? Yeah. I want a new drug. Yeah, I don't want a new drug. I don't know about you. I want an old drug, right? I want a drug that we know something about. I don't want a new procedure. I want a procedure that's known to work and my doctor knows how to do. And I don't want a new device. I want one that's thoroughly tested. The assumption is newer is always better, but the disturbing truth is new interventions are typically not well tested, and they often wind up being judged ineffective or worse, even harmful. All right, I know you guys need to get to work, so let's get to the last one. And the last one is it's all about avoiding death. And I want to be clear that we're entering value judgment territory. And everybody has different values, and that's fine. And in the last few minutes, I'll just share with you mine. I'm not saying they're right. I just say these are issues we all need to think about a little bit. And many of us were drawn into medicine because of our interest in saving lives. And I'm no exception. This This is the last picture I'll show you of me. It's in 1975, my hometown of Boulder, Colorado, and I worked on the county ambulance service. And as you can see, I thought it was pretty cool. Very cool, in fact. And then some of you are looking and say, wait. Isn't that a pocket protector? Come on, you're not cool. Yeah, right. It's just and I love this work. I really love the the excitement and blood and and dealing with the fire department, the police department, and being starting IVs, all that great stuff. And I have to say at the same time, and I like music, so I got to tell you, this song came out. We'd be driving around town like this. So we just thought it was the greatest thing. And we talked about saving lives. And of course, this is very evocative language, right? Saving lives or avoiding death. Very, very evocative language. But it's shorthand for, terms that maybe aren't quite so evocative. Lengthening life and delaying death. And I don't know if you kind of feel the emotional change from the yellow to the blue, but if you do, you kind of know how these things begin to feel when you really start thinking about what's going on. And sometimes I think our judgments about the medical literature, if we see a mortality benefit, we should do it. Any effect on mortality. It's like a trump card. If you got some effect on mortality, must do it. No matter what else happens. But is length of life the only relevant variable? Now, I don't spend a lot of time on this website, but someone directed me to this is Sermo. This is a social networking site for physicians. And they asked physicians this question: which one of these diseases are you personally most afraid of developing or contracting? Here is the most common cause of death in the country. That's not what doctors are worried about, right? Their number one concern is living too long, right? They're worried about Alzheimer's disease. It's not all about avoiding death. It's not all about avoiding death. Really? I mean, if that was true, why don't we lower the national speed limit back to 55? Some of you remember Jimmy Carter did this as a way to save gasoline. A side effect, National Highway Safety Administration estimated it was about 3,000 lives were saved a year. As I said, I'm from out west. I can tell you, no one's going back to 55 in Colorado, Montana, Utah. But even Western Mass, you're not going back to 55. Why do we climb mountains? Full disclosure, this was like one of my favorite trips. This is the Alaska Range. That's my wife, Linda. And I know it's not a great picture of her, but it was, you can see a lot of her. Yeah, right. But it was totally glorious. We were so far off the grid. If it was all about avoiding death, why would I ever do something like that? Why do we swim in the ocean? Honestly, I love swimming in natural bodies of water. I swim in the Connecticut upstream here. I like getting in little brooks. I like going in lakes. I love going in the ocean. I just love to swim. And so I thought, well, let's go to the CDC. Let's find out how many deaths are there in natural bodies of water. We're not talking about people diving into swimming pools that aren't full. We're not talking about boating accidents. We're talking about swimming natural bodies of water. There are 1,500 deaths in the United States each year there. What's the appropriate policy response? Close the beaches? I don't think so, and I don't think you think that either. It's not all about avoiding death. You know the disturbing truth that a fixation on preventing death diminishes life. All right, I want to come back where I started. Medical care can do a lot of good in selected settings, and I know you all know that, and I want you to know I know that, and as you go out to work today, I hope you do good. Particularly people who are acutely sick, acutely suffering, injured, what you might call acute care medicine. But at the same time, we have exaggerated the benefits of medical care in many other areas, and we've understated its harm. And my challenge for you is, can you help communicate this nuance? Thank you very much for your attention. I'm happy to answer any questions. Okay. Yes.
As we have more quality metrics and
Oh.
things that we have to hit, I have a feeling it.
Yeah, so let's just, performance measurement, unfortunately, is defaulted towards preventive interventions because it's easy to measure, and that, I think that's been a huge mistake, and it's now pushing people to do things to patients that they wouldn't want if they knew the full story. It's a huge problem. It's a huge problem. Yes, sir.
Your Alaskan physician friend should have chosen to get his cholesterol checked. That would have been much more appropriate.
Yes. I'm not quite sure why he did it, but yeah. He was pushing back. And yeah. But the EKG was totally stupid, and he wished he never got it. But you can imagine us all getting in the same situation, and I thought it was really powerful. And I guess I can imagine this too. You don't want to be too hard of a patient.
I had a patient who was a young patient who had like atypical chest pain. He looked funny. He was a bit of a soccer player, a prep athlete.
Right.
We eventually had to end his career. I don't know if he did the right thing.
Right. This is very
You're not
hard.
going to die on the soccer field.
Yeah.
You might still die.
Right. He probably will. Just knowing what little I know.
The problem was you identified it.
Yeah. Right. It's tough. Yeah.
Although hindsight is 20/20.
Yeah.
He, in retrospect, he didn't have anything of significance. I mean, so if the scenario had been different and he had a valve or he had something else, the question is, can we be more nuanced about how we talk about the it may be that more information is not better or worse. It's just the way we talk about the information.
I think I definitely appreciate it, and I get various forms of this question all the time. Gil, it's not about diagnosis; it's about actions taken on the diagnosis. But I don't, and I think that's very important. I'm very supportive of all the new active surveillance efforts in cancers and so forth. That makes a lot of sense. I'm glad it's available, but I don't think we should diminish the labeling issue of what it feels like to get a diagnosis of cancer, even if you're going to watch it, or get a diagnosis of an abnormal heart, even if you're just going to watch it. And so we shouldn't ignore how powerful that is in driving subsequent events, whether it should be or not. And so I think we've got to limit, well, at least I want to limit in myself how much information I have about anticipating what my next 20 years look like, or my next 5 years. I just don't want to spend my life thinking about that. And one of the things we also have to remember is timing of events is huge. This issue of anticipating the future with this information, has a way of creating side effects right now when you take that. And to me, at least personally, that time element's really important. Yeah.
This is probably more a comment. Obviously, medicine
Comments are welcome.
advanced, in a way, NIH have changed
Yeah.
the way that they want to do diagnosis early and genetic.
Right.
And yes, you have 38 million data bits that you have to eventually look at which are the ones that are really important and the ones that are not.
Right.
That is going to take years. I mean, obviously, we have deciphered the genetic code, but
Right.
there's still bits that are not translated into any protein, and that will take years. That
Absolutely.
doesn't mean that we should stop.
But I'm not stopping research. I'm not. But
I don't think you can.
Yeah.
But I always say medicine is also common sense.
Yeah.
If we get, here's one problem. The data you show is very important for us. Now, a problem is when you face one patient and you have to make the right decision. We get pressures of
Sure.
different kind of levels, productivity, the possibility of a suit if you don't
Right.
get it ready. So I would say yes, probably you have to sit down and see how this evolves and try to evaluate, at least in lung cancer, cancer,
Right.
which are the patients who
Yep.
really need the intervention.
Right.
And we
Making
discussed-
use of the diagnostic
Yes,
value of time.
And we discussed that briefly yesterday. For the lung cancer screening, yes, every month we meet a group of, radiologists, pulmonologists, surgeons, and we look at which are the ones that are, out of 150,
Right.
to give you an idea, 20 are worrisome, and we
Right.
follow them.
Right.
We only do interventions on the ones that we have demonstrated.
Right.
That say a 3-month follow-up is growing.
Right.
And so it's well taken, your advice.
Right.
Probably wait, sit down and see what is happening.
And the other thing I just want to expand your view is that there's some patients who may make a total rational decision is I don't want to play that game. I don't want to
You
play that
have
game.
to leave it because it's a
Right.
concerted decision between the
Right.
patient and the physician.
Yeah.
So there are things that.
Right. Some may say, I want to play that game. I understand that I undergo the risk of overtreatment or side effects from treatment. But I don't want to be medicalized prematurely, and I accept the possibility that I may be foregoing some small benefit, particularly when that benefit is small and uncertain. As opposed to dealing with a problem that I have right now, where the potential for help is much higher.
How about
Yeah.
binary thinking? Like it's a benefit or not.
Yeah. No, then it's always a mixture. Yeah. Right? I mean, and the net effect is, it ultimately involves combining very different outcomes. Right? The minute we acknowledge it's not all about death, it's about how patients feel and their sense of resiliency and what matters to them, and their pocketbook, their finances, all of a sudden it becomes a multivariable equation with a lot of utilities that are unknowable. And so all this ultimately involves some value judgments of how we want to trade off things.
It almost seems like you say to the patient, before you see me, how much active risk reduction are you interested in? And then it almost sets a ceiling on things you need to investigate.
And to some extent, I encourage, I actually think I did it in my first book. I have this little drawing of sort of the spectrum of where you sit on the aggressiveness of medicine. Do you want to pursue everything that might have a potential benefit, or do you value pursuing health and not getting knocked back with information that may make you worry about yourself and accept the fact you might be missing a small benefit? And there's no right answer, and it is a spectrum. But I think often we presume, and we've also marketed, we've sort of exaggerated how much difference we can make, that everybody wants to anticipate everything and wants as much data about themselves as possible. And it's partly we haven't acknowledged that anything harmful can come out of it. Yeah.
I think this, one of the things that, I guess, the metrics that we're being measured on now, and one of the things, or things that actually makes patients quality, I think, perceived higher quality is shared medical decision making.
Yeah.
And one of the things that I think this is really helpful in is that I think you have to, in the uncertainty, you have to approach it, but you also have to have the knowledge.
Yeah.
So sometimes I'll see patients, with, I'm a cardiologist, and so
Right.
they'll have, I asked about the cholesterol.
Right.
Their cholesterol's high. I saw this attorney one time who had high cholesterol, and this was back when they were checking CRPs, and
Right.
CRPs were persistently elevated, and I was referred as a consultant, from his primary to check several cholesterols. In the end, I said, well, there's like a reduction of 1.3 to 0.8% the risk of death or MI. I forget how many years out from the study, and from the Jupiter study, and so you should take a statin, I guess, if you believe in this.
Yeah.
And he didn't want to take it.
Yeah.
So in the end, he didn't want to. So I was trying
Right.
to go. So another thing is that I remember back when
And can I just say one thing about Jupiter and that decision? And the person that wants to take it and then develops muscle problems can feel good about stopping, right?
But I think in the end, you can see the risks are actually pretty low, but
Yeah.
the benefits are not great. But,
Right.
but he didn't.
No, I think the risks are.
All of the testing was useless because in the end, it was what he wanted to do,
Right.
which is nothing. Another situation is back when the mammogram, 40 to 50 mammograms,
Right.
I talked to an obstetrician who said in her group, goes, well, our group's practice is to start at 40.
Right.
And which means you're treating all of your patient as cattle.
That's right.
The patient makes no difference.
And unfortunately, we were encouraged.
You were refusing to treat your patient.
We were encouraged to do that because it became a performance, right? It became a way that healthcare systems, produced a report card that showed how good they were.
Can I add something else? So for example, we get this CT scans report where the radiologists say there has been a slightly change of, and they make a recommendation.
Right.
Like, let's do a PET scan, let's do consider biopsy. So then it's up to you to say, look, I respect your suggestion, which is written there, but I will disagree. And then you talk to the patient, and then you have to tell them, look, I disagree with this. But many times, if the patient doesn't come to people who have similar process of thinking as you were mentioning today, they will go for procedures, just like that, because what we are afraid that if you miss that cancer,
But you've already
somebody's going to come back
started,
to
the
you.
CTs themselves have already started the train in motion. It's not the radiologist,
Right.
it's the procedure
It's
of
yours.
screening.
Right.
The train's already in motion.
Right.
When my internist, when somebody ever come in and I get a PSA check because I turned 50, I refuse.
Right.
See,
You have to-
but you have to be willing to have this.
Can't start the train in motion.
I was a VA person up until 2015, and we had these discussions about PSAs all the time. The conversations go like this: I don't routinely do them, and people, of course, would come and say, "Well, I want this done," and I would say, "Okay, I'll do it as long as when it comes back, we don't jump to any decisions. We have a discussion about what it means." And how we're gonna deal with it going forward, because the data are all over the place in terms of what to do. So it's sort of how you couch the information. And the other thing is, if you have a patient who is like a compulsive personality, who's gonna obsess about it for the rest of their adult life, you might say, you know what, I think for you, it's probably not a good idea. But if you have somebody who can compartmentalize and say, okay, I can
There's
sort of
no
live with that
utility
uncertainty.
Right.
Part of that is knowing your patient.
Can I just add, since we're talking about CTs and then move to PSA, and the way you prep the patient for a PSA, I want to make sure we talk afterwards in which way. In some ways, I think this is really important for all cross-sectional imaging, that we prepare patients for, there's a high likelihood that we'll find something unrelated to what we're looking for. We're going to have some other issue will come up, and I just want you to know that at the outset, and that you're prepared that my best suggestion may be I'm going to suggest we do nothing about that, even though the radiologist says there's an abnormality there or there. And I do think preparing patients for the ambiguity of the answer is an important step for when we do that kind of testing. Yeah. Well, you guys should probably go to work. I'm supposed to we got a storm. Have a great day.